Welcome back to the second episode of the Basal Ganglia Made Easy series. If you have not watched the first episode, I would highly recommend that you go and watch the first episode and then come back because we'll be continuing exactly where we left off in the first episode itself. So, without wasting any more time, let's see what we have got in today's episode itself. So today we'll be seeing some aspects of the circuits. Like last time we had covered the putamen circuit. Today we'll be seeing the caudate circuit and also the cognitive control of how basal ganglia is heavily involved in the cognitive control of the motor patterns. We will also see the function of basal ganglia to change the timing and to scale the intensity of movements. For that, we have some small exercise planned with you guys. And lastly, we'll be seeing the different neurotransmitters. We'll be just touching upon the different neurotransmitters that are present and how they are, active in all this complex circuitry of the basal ganglia itself. So, grab your seat belts. Let's start. All right. So, cognitive control of the sequences of motor pattern. Last time when we discussed about the functional anatomy, we had actually seen, like I had actually discussed regarding how the caudate would be heavily involved in the cognitive control of the motor patterns we do. So most of our motor actions occur as a consequence of thoughts generated in the mind. All right. So whenever we are trying to do any motor activity, such as picking up a bottle, sliding off your phone, texting, even the small thumb movements that we do, they are somehow planned and controlled cognitively. All right. So minor sequence patterns such as texting, or maybe some larger activities such as walking, holding a bottle, drinking from a bottle, drinking for a cup, any motor activity that you do, you have certain kind of cognitive control. And that is basically processed, you can say modulated. Again, I'm repeating the word modulated because basal ganglia directly does not create a movement, directly isn't responsible to create a movement, but rather it modulates this. The caudate nucleus here plays a major role in this cognitive control of motor. So whatever motor actions that are cognitively done, like you think for a process that I want to pick up this bottle, I want to pick up this pen and start writing, that cognitive control is basically modulated, or the caudate circuit here plays a major role in controlling. The neural connections between the caudate and the nucleus and the corticospinal motor control system are somewhat more different. So, understanding that when we are talking about pure motor activity, it is done by the corticospinal motor control system. But when we are talking about modulation of that motor activity, we are talking about how the basal ganglia might be responsible in bringing out that cognitive flow of that particular movement. Now, why this caudate circuit is important is because when we are going for quick reflexive activities, such as might be you might be riding a bike, there might be a car just coming off and you just dodge it and then come it again. So at that specific small moment of time, you will be using the caudate circuit is heavily responsible in planning out. We'll be seeing this in a little ahead as well. So the caudate nucleus extends into all the lobes. As seen when we were going through the anatomy, we had seen the C-shaped structure of the caudate. So it extends to all lobes of the cerebrum, beginning anteriorly in the frontal lobes, then passing posteriorly to the parietal and the occipital lobes, and finally curving forward again like the letter C into the temporal lobes. Exactly how we had seen this is the previous image, if you can remember in the first episode. That is why I highly recommend to watch the first episode. All right, so you can see this shape of the caudate, this complete C is oriented pointed in such a way that all the connections from the cerebrum would be coming to the caudate itself. So anteriorly, we might get connections from the frontal lobe, from this parietal and sensory motor areas, posteriorly from the visual and the auditory fields, and then curving back again. Now, why is this a C shape? Why the caudate has to get that much information? Why is that C shape so important? Because that when we are talking about a movement, a cognitive control of the movement, the caudate actually perceives you as a person. Basically, let's have an example. We'll be having an example forward as well, with a bottle that is in my hand. So I have to understand where in space this bottle is, how my hands would be grasping it, and how we would be taking it outside or using it in a differently spaced area. So the cognitive control of the sequences of motor patterns, the caudate circuit. Furthermore, we have to understand of how the caudate nucleus receives the large amount of input. Again, we had discussed, I just said it, that the reason the C shape is because it has to get as much as information about the space and environment, which can be, and the perception of the environment space as well, to initiate that cognitive controlled motor pattern. All right. This picking up a bottle is a relatively easy example. We'll be moving to a very complex example in front as well. So it gets a large amount of inputs from the association area of the cerebral cortex overlying the caudate nucleus, mainly areas that also integrate the different types of sensory and motor information into usable thought patterns. After the signals pass from the cerebral cortex to the caudate nucleus, they are next transmitted into the internal globus pallidus. Don't worry, I'll be explaining the complete circuit again. Don't worry, we'll make it very easy. Then to the relay nuclei of the ventroanterior and the ventrolateral thalamus, and finally back to the prefrontal, premotor, and supplemental motor areas of the cerebral cortex, but with almost none of the returning signals passing directly to the primary motor cortex. You have to understand again when I think we'll be moving towards the circuit. Okay, here is the circuit itself. Now understand, when we were discussing regarding the putamen circuit, we were getting some connections directly from the primary motor area, but here it's not the case here itself. So you can see that we are getting a caudate circuit. So looking at the caudate circuit, we understand that we are not directly getting any motor signals from the primary motor area. We are getting signals from, you can see, you can getting inputs from the prefrontal area, the premotor and the supplementary area, some from the primary motor area, some from the visual and auditory cortex, and some from the auditory, you can say the temporal areas as well. As you can see, after we get the signals, the caudate then transfers this to the globus pallidus internal. So yeah, I can see this. This is the globus pallidus internal. From the globus pallidus internal, it goes to the ventroanterior and the ventrolateral thalamus of nuclei, and then again to, you can say, the prefrontal area or the frontal areas. You can see there is no direct connection to the primary motor areas. That is why I told you that the BG is not directly responsible for initiating a cognitive, you can say, cognitive motor or a voluntary motor pattern as of such, but rather it actually modulates it. Now, to understand how it modulates it, we have to see that the specific components of the circuits, that even after all the sensory perceptions that are coming in to the caudate, you can understand that when it throws back, when it gives back the processed information back to the thalamus, from the thalamus back to the brain, it is still being sent to the frontal area. So that gives, so this becomes a little different than a reflex. Understand, when we have a reflex, it's just a reflex, but when we are talking about a split second coordinated cognitive controlled movement, when you see such as contact sports, like badminton players, footballers. They in a split second they actually change their direction, but they are still in complete control of their activities. So your caudate is specifically very responsible in the smaller activities. So going back, signals that are going. So you can see the back. They go to the accessory motor regions in the premotor and the supplemental motor areas that are concerned with putting together sequential patterns of movement lasting 5 or more seconds instead of exciting individual muscle movements. So the sequence of a pattern is also heavily responsible because the caudate will be pushing out some blocks of information of how a pattern will be generated. Just the pattern will be generated, and then the motor association areas will set it in a particular sequence. But the caudate helps in understanding of how even in a small specific moment of time, such as some like a few seconds, you plan out an activity that might be very complex in terms of movement, and we'll be seeing that in an example very soon. So just going back again and understanding the circuit, so you have to understand there are no direct connections from the primary motor area, nor are there any direct connections that are going from the circuit to the primary motor area again. So again, it is the processing of the information, sequencing, sending it back to the association area, and then sent to the primary motor area for the execution itself. Now, what will you do when you see a lion? All right, what if you are sitting home comfortably right now? If you're watching this on YouTube, you'll be sitting home and you'll be understanding, okay, if you're just sitting home, what will be your first reaction? It's most probably to run. All right, so run away, but run where? All right, you'll be finding an exit and just running, sprinting past that. All right, if you see any danger, so that flight or that response of getting up, going, turning around, and then going to the exit area, so you'll be running for your life. So in that small particular seconds, do you think that you will be actually getting up? Or maybe let's talk in physiotherapeutic and more medical movement kinesiological terms. So you can say, do you think that you will be placing your knees properly on the ground, placing your foot properly on the ground, aligning your knee, transferring your weight of your trunk ahead, and then slowly getting up, then turning around, then looking at, then perceiving where the exit is, all right, in that split second, then turning around and then running towards taking a first step, a second step, a third step, a fourth step, increasing your acceleration and the power of your muscles again and again and again. No, you won't be thinking that. You would be thinking just one thing: I gotta run. Then who, there must be something that will be doing all this processing work, all this sequencing work of if you're sitting down and running. Like if you're sitting down, right, your line comes and you have to run. That whole motor activity pattern that is planned out, that is modulated and controlled by the caudate. So again, just as we explained this example, a good example of this would be a person seeing a lion approach and then responding instantaneously and automatically by turning away from the lion, beginning to run, and then even attempting to climb a tree. In your and my case, running outside of our houses and running out. All right. Without the cognitive functions, the person might not have the instinctive knowledge without thinking for too long a time to respond quickly and appropriately. Yes. So without cognitive function, you wouldn't recognize where to run. If you don't have that cognitive insight of the areas, your space in the environment, where the exit is, how farther the exit is, how many steps would it require to reach it, how much power or acceleration would be required to give that maximum velocity to your gait, or you can say to your run, to exactly go ahead and actually get out and be saved from the lion. So all that micro processes, all that processes of thinking is actually, you can say, that cognitive thinking. Caudate circuit plays the major important role here. Now, thus, cognitive control of motor activity determines subconsciously and within seconds which patterns of movement will be used together to achieve a complex goal that might itself last for many seconds. So, you have to understand that when you have to run outside, when there's a lion, when there's a danger, or you can say, all right, let's take an example. You are in your practical exams, right? And you are done final exams of any course that you're doing. You're done. You just, you're very panicked, and sudden something goofs up. You try to improvise in a very, very small fashion. Maybe your patient, when you are treating a patient might be falling. All right. I'm talking about you as a therapist right now, so it's more easy to understand. So you directly go for some small adjustment, either holding the patient might be falling, you just hold your hand, you just step ahead, you make that control of your own body to hold your patient if your patient is falling while treating him gait or something. That is from your side itself. Coordinate is so important. Then understand how much important it is when it is actually a pathological conditions that you are treating. So, for all my clinical therapists and students who will be treating patients, you have to understand that when there is a BG injury, you have to have some small idea. When you see that, okay, there might be a basal ganglia involvement, the choroid might be affected. Uh, don't just ignore the cognitive side. Don't ignore the cognitive side. That there might be some cognitive sequencing and planning issues. So here you understand the sequencing, how chordate plays an important role in the sequencing. All right. So we'll be now understanding how timing and the scale of the intensity. We just understood about how chordate might the chordate circuit and how it might be involved in the sequencing. But now we'll be understanding the timing and the scale of the intensity of movement. So the before starting off, if you have a cup around, maybe if you are looking from your phones or tablets, all right, right now you are using that timing and sequencing itself, the intensity at which you're holding your maybe your phone to look at this video exactly, to understand that your biceps, your triceps has to co-contract in a specific way to keep that intensity of your arm length to your eyes. So understanding that you right now are using your BG, all right? Good. I think that that might solve, like, open up your. So the reason I'm saying this is to observe. First, starting observe your normal movements in time in scales of understanding the timing and sequencing. And when you have a patient with a basal ganglia pathology, you will start understanding the symptoms, understanding and observing the symptoms accordingly as well. All right, so let's move on to the timing and scale of sequencer. Yeah. So two important capabilities of the brain in controlling the movement are to determine how rapidly the movement is to be performed and how large of that movement will be. So here comes some, you can say, most of our therapists will use the word coordination. um, it's a good word, but it doesn't actually, gives us a good understanding of what actually that coordination is. When you're talking about, you have to understand whether it is timing, whether it is sequencing, whether it is the intensity or the amplitude of the movement. So here we are talking about how rapidly the movement will be performed and how large the movement will be. So the speed of the movement, if I want to drink a bottle, I have to go very slow so that I can sip out. You can sip out the water. All right, I can't just be pouring it on my head directly if it goes very fast. So if it is very fast, very bad, very slow, I might not be able to drink it. So it should be optimal. And this thing that is optimal for me might not be optimal for you, because our height, our body weight, structure, arm length, is a lot of categories that are coming. So you understand the complex, the C shape of the chordate. Why the chordate requires that much information is to understand how the movement will be performed, how far the bottle is to keep my grasp up and take it back down. Don't worry, yes, it's very easy. You can start relating all these instances of how the chordate might work in normal conditions, because after that only you'll understand of how the pathological involvement of the BG might get involved if there's a damage of the chordate. Second is how to control a large movement, how large the movement will be. So if I want to take this bottle, all right, I have to keep my amplitude very less. I can't be having up, no, not functional. All right, might be I might miss it. All right, if the amplitude, if the bottle is so near, I have to give my amplitude a little rest. All right, with that speed as well. So yes, you have some cognitive ability to think it, but when we are actually picking up rolling stuff, writing, that actually changes a lot, because that is actually very variable. So we do not think every time cognitively. That work is handled by our, you can say, coordinator. Now, I have a small exercise for you all. If you will be take a minute, you can start writing letters, your first name letters, in a big format and a small format. And you can give this same exercise to your friends and see how they write it. So, like we are a part of H Physio Academy, that's why we have H. So it's a bigger H, smaller H, H, H. So it's not, this is a text test. No, I want you to handwrite it. All right. So take a paper and pen. Start writing your first letter in a big, take a big alphabet first, and then your second go smaller, smaller, as small as you can. Will take a minute. If you can pause the video here and do it, that will be fine. All right. So I'll just pause for a moment here. All right. I think that's enough. Okay. So if you have written it, well and good. If you have made your friends or anyone write as well, great. Let's move on. Little see, and why did we do this? Now to understand this, it is a very important aspect that you'll be understanding that some of you might have been writing it very fast, some of you might be writing it very slow, some of you might writing it with different sizes. But whether you change the size of the alphabet or the speed at which you write, all right, you can see that the pattern of your alphabet will not be changing. The pattern will be the same. So the pattern that you've learned of, through your childhood, this sequence of H, for me it might be H, for someone it might be A, someone it might be O, L. You can go on and on. So understand that even though you write the alphabet very big or very small, the pattern does not change. So regardless, you can say a person may write the letter H slowly or rapidly. He or she might write it small on a piece of paper or large on a chalkboard, or maybe the exercise that I've told you, if you write it on a paper or anywhere. Regardless of the choice, the proportional characteristics, the characteristic of the letter that you are writing, all right, for here it might be H. So yes, you will be going for two lines or a straight line like that. Some people write straight and then H, all right. Some, if you, A is very variable. So the pattern that you have learned, in which you are habituated to write, that and the proportion in which you write your alphabet, that remains the same. So in patients with severe lesion of the basal ganglia, this timing and scaling function is poor. In fact, sometimes they are non-existent. So yes, you understand, even if you write it fast, even if you write it slow, you can see that there is some proportional similarities in your alphabets. Ekdam fast, matlab, if you're writing very fast, yes, your handwriting might be really bad, right? It might be you have a very bad handwriting or a basal ganglia lesion. So no, just kidding. So understand, if you are writing a big letter and a small letter, the proportional characteristic of the letter does not change. The way you start off with your take the pen, make the pen step in contact with the paper, the way you write the alphabets, the flow of your alphabet, that particular that takes timing and sequencing. So when you get a patient who you are suspecting that he might be having, starting symptoms of basal ganglia lesions, always check their handwriting. always check their handwriting by doing this simple test. Make them write big words and small words and see whether that proportional characteristics of the letter might be different. Yeah, there might be different reasons as well. Don't worry, you can go for a differential diagnosis of whether there is some hand issue, there is some coordination issue, there might be a cerebral lesion. No, when you are very definite, okay, all those differential diagnoses are quick-witted and you are reaching to a point of diagnosis that this might be related to some basal ganglia injury, or you might have investigation showing that there is a basal ganglia injury. Test this out. It will help you understand of how the timing and sequencing of the pattern is very much affected in such kind of patients. So to understand how why this understanding of the timing and sequencing is important, because when you go ahead and treat patients, when you go ahead and treat patients with BG, you have to incorporate training, the sequencing and timing, not in just fine motor activities like writing, but activities such as gait. If you want to train gait, the timing and sequencing of the complete gait cycle should be retaught to your patients, should be your focus of your treatment. So I'm just giving tips and pointers. It should be collectively seen. Every patient might have a different timing and sequences according, again, due to their body composition, their height, and the issues, maybe the spasticity, rigidity, all that stuff you have to understand, and then give up that timing and sequencing matter most importance, because that will help you to actually treat patients with severe kinesia such as Barkey. There might be you can say tardive dyskinesia, Huntington's. These all cases you might be very rare, but you might be going in rehabilitation of these kinds of cases. So you have to understand, yes, the basal ganglia is involved. There might be some affection of the caudate. There might, if there's a summation of caudate, there might be a timing and sequencing problem. That's how you expand your horizon just from doing coordination exercises. So it's not coordination exercises. It's timing, sequencing, speed. Availability of the space, of how the patient is oriented. Very much unfocused sometimes, but you have to understand that you have to keep that in mind while treating your patients. So coming back to our topic, yes, we'll be moving ahead with some basic touching, because this is a very fine neurochemistry topic, but to understand just some of the receptors at the different pathways. So we understood the putamen and the caudate circuits, the two bigger pathways. Will be moving forwards with now almost all the complex you can say connections, I believe, have been understood and made cleared out. uh, Now to understand the dopamine pathway. So substantia nigra to caudate nucleus and putamen. All right. So the dopamine path, there are different pathways throughout the complete basal ganglia circuitry. So to understand that the different nucleus, how they coordinate with different channels, we discussed about the inputs, the afferents, the efferents from the episode 1 and episode 2 today, that we saw different aspects of how the nucleuses are connecting to different aspects such as GB interni, the globus, sorry, GP, the globus pallidus interni, externi, how they are connected to the caudate circuit, how they relate to the putamen circuit, how ventro-anterior and ventrolateral thalamus is connected to that. So all these pathways, there are different neurotransmitters with different neuroreceptors as well. So the dopamine pathway, the most well-known, I think, part of the aspect of the, you can say, basal ganglia is the caudate nucleus and putamen, and how substantia nigra has a dopamine pathway to the caudate nucleus putamen. We'll be discussing this in detail when we'll be discussing the pathologies in more ahead episodes, thoda sa, again. But right now we have to understand that the dopamine pathways are majorly from the substantia nigra to the caudate nucleus and putamen. We get gamma aminobutyric acid. The GABA pathways are from caudate nucleus and putamen to the globus pallidus and the substantia nigra. And the acetylcholine pathways are from the cortex to the caudate nucleus and the putamen. There are other neurotransmitters such as norepinephrine, serotonin, and enkephalin. Okay, a simple diagrammatic representation of this is given here. So there are different, so you have to understand that when we are talking about BG, it is not just one neurotransmitter for everything. No, there are different neurotransmitters for different nuclei as well. So for you can see the substantia nigra, we discussed about the first one. So you get substantia nigra having dopamine pathways back to the caudate nucleus and the putamen. You will be getting the GABA pathways here, as we discussed before, the GABA pathways from the caudate and nucleus putamen to the globus pallidus and the substantia nigra. So you can say these are one-way pathways. All right. When we are talking about neurotransmitter pathways, we are talking about one-way pathway. So if some signal might be going from the substantia nigra to the caudate nucleus, you have to understand, okay, that is the dopamine pathway. All right. So when we are talking about dopamine deficiency, we are dopamine deficiency or dopamine pathology, dopamine secretion pathology, dopamine reception pathology. We'll be talking about, okay, we know that substantia nigra to the caudate nucleus and the globus pallidus. So we are, if there is a dopamine secreting issue, we'll be understanding that it is a substantia nigra that might be involved. All right. If there is a reception issue, we'll be having the caudate nucleus and the putamen. But it is not fairly that easy. What I'm telling you, it's a very complex aspect, understanding the neuromicrobiology of these nuclei, that is still under very heavy research, and good research is coming up. But for today's scope of our episodes, we have to just understand, okay, from substantia nigra to caudate and putamen, we have the dopamine pathway. From the caudate and putamen nucleus to the substantia nigra, we have the GABA pathways, and then there are acetylcholine pathways as well. Now, to understand why this neurotransmitters are important, when we go to the pathology side of it, we'll be understanding some small aspects of there might be acetylcholine deficiency, GABA deficiency. When we are talking about basal ganglia, you might be coming under reports when you have, neurologists might be explaining this and that. So we have to have a certain amount of idea of how these neurotransmitter pathways will be working. So yes, the acetylcholine pathways, major pathways that are coming from the cortex, from the cortex to different aspects. So when we are getting afferents from the cortex in any pathway, it is majorly the acetylcholine pathways. There are other neurotransmitters such as norepinephrine, serotonin, enkephalin, many more are also there. So from brainstem, when we are considering the basal ganglia, from the cortex we are getting acetylcholine. From the substantia nigra to caudate nucleus and putamen is the dopamine. From the caudate and putamen back to substantia nigra are GABA pathways, and the globus pallidus internus and externus as well. We have the GABA pathways, and there are some if you can say afferents coming from the brainstem, is the non-afferent serotonin and enkephalin. So this was just to have like a general idea of all these neurotransmitters. So it is not just one neurotransmitters, a lot of neurotransmitters are involved. So I think that will be the end of our second episode. I hope you enjoyed if you have not watched the first episode and you've just come to the end of this, go back and watch the first episode, because we've covered a lot of neuroanat in that. And we'll be moving forward to a bit of the pathological aspects. The clinical therapist, and you are interested in treating the conditions. Now, all that we've learned rehab, when we are talking about all the pathways, and this, we'll be seeing some two major important things in the next episode. That is the loops, the direct and the indirect loops, and how the basal ganglia controls tone, and controls that particular movement. We'll be seeing that in the next episode, and I hope you've enjoyed it. Thank you again for joining into Physio Academy.